Good morning. My name is Anthony Wang. I'm a pediatric neurosurgeon here at UCLA, and today I'm going to spend a little bit of time talking about Chiari malformations in children. If you have any questions through the presentation, please feel free to send them to this link above. So a little background on what a Chiari malformation is, because sometimes you'll hear different names associated with this. The Chiari malformation, it describes an anatomic variant in the posterior fossa where the cerebellar tonsils sit lower than they should. Sometimes other structures also sit lower than they should, and sometimes there are other associated abnormalities. So the first, probably the first description of a Chiari malformation was provided by Cleland in Glasgow, where he described what turns out to be what we now call a Chiari 2 malformation. The name Chiari malformation came from this gentleman, Hans von Chiari, where in the 1890s he described, again, anatomic variants on pathology where the cerebellum was sitting lower than it should. Later, another Austrian pathologist, Arnold, his students found a similar appearance from a totally different etiology. They described probably what was a Chiari 2 malformations and gave it the name Arnold-Chiari malformations. Now, this name is no longer used, and the current nomenclature includes Chiari 1, Chiari 2, Chiari 3 malformations, as well as a rarer kind of variant described by the Birmingham group, Chiari 0 and Chiari 1.5s. We're going to talk mostly about Chiari 1 malformations today, but just as a little background, what is a Chiari 1 malformation? Well, a Chiari 1 malformation is just the appearance of cerebellar tonsillar descent below the foramen magnum to a certain length below the foramen magnum. We'll talk a little bit about what length that is, exactly what the cutoffs we use are for screening. Now, Chiari 2 malformation, what used to be sometimes called the Arnold-Chiari malformation, but no longer is the descent of the cerebellar tonsils as well as some of the brainstem structures through the base of the skull, but in association with a condition called myelomeningocele, which is a malformation at of the spinal cord. This is a totally different pathology than Chiari 1. It's a neuroectodermal pathology, as is Chiari 3, which is the same imaging features, but in relation to an encephalocele, so an outpouching of brain tissue rather than spinal cord tissue, in association with this same kind of downward descent of neural structures through the foramen magnum at the base of the skull. So, let's see. Can I borrow that? What does a Chiari 1 malformation come from? Well, Chiari 1 malformation is a mesodermal anomaly. There are several theories as to how it comes about. One is that there is a genetic predisposition to its occurrence. It is thought to be sporadic in that it's not inherited through families. Another theory is that it occurs through downward pressure from above. So conditions like hydrocephalus or kind of a surplus of cerebrospinal fluid, pressure from above might push these structures down. Another potential etiology of a Chiari 1 malformation is being pulled from below. So if there is a leak of spinal fluid in the spinal cord, and kind of a pressure differential that might pull it down. One theory, one leading theory as to why this happens in children is kind of the hydrodynamic pulsion theory, or water hammer effect, where the cerebellar tonsils are lying a little bit low and are pushed downward in kind of a pulsating manner that that causes compression on brainstem structures, and sometimes even scarring, which worsens the effect. In children particularly, we see syringomyelia in around half of cases when they show up. Oftentimes, this is what they come to us with, is a diagnosis of syringomyelia, and then we find the Chiari malformation. Other times, the syringomyelia might cause another condition called scoliosis, an abnormal curvature of the spine, and in routine screening in school, someone might find that a child has scoliosis, and then on further workup find that there's a syringomyelia associated with a Chiari malformation. Now, what is a syringomyelia in relation to a Chiari malformation? A syringomyelia is abnormal fluid within the spinal cord itself. And one theory is that as CSF pressure is increased by the downward pulsation of the cerebellar tonsils, that CSF pressure builds up and causes fluid to leak out into the tissues around the spinal cord, within the spinal cord, and causes this buildup of fluid that shows up as a syrinx or a syringomyelia. Syringomyelia will present typically either as scoliosis or as what we describe as a suspended dissociated sensory loss, in that it happens at the level, the sensory loss happens at the level where the syrinx exists, and that that the pathology occurs from the inside out. So very frequently you'll experience loss of pain and temperature sensation before you experience other types of sensory loss. The other really common presentation in children is headache, but a very specific type of headache. We describe them typically as tussive headaches. They're headaches that occur with straining, sometimes bending over. Coughing is a very common reason why these headaches might come about. Other times we'll see brainstem compression or cranial nerve compression symptoms. Here we might see central sleep apnea, might see vocal cord paralysis, might see nystagmus, which is abnormal movements of the eyes. These are all mediated by the lower part of the brainstem, where that crowding really occurs the most. Finally, we might see problems with cerebellar function, dizziness or clumsiness of gait or of the hands. Now, we diagnose Chiari almost exclusively on MRI these days. Barkovich's group kind of established the reasons why we use the cutoffs that we do. The cutoffs that we use are typically 3 millimeters to 5 millimeters of tonsillar descent below the foramen magnum, below the bottom of the skull base. And this is the reason why we do, because when we get out to 5 millimeters below, we get 100% specificity based on his study, and this has been largely reproduced pretty reliably over the course of the years since that was first described. Radiologists will very frequently use somewhere between 3 to 5 millimeters as a general cutoff when we're screening MRIs to say, hey, this person might have a Chiari malformation. Now, for adults, we use kind of a lower number as a cutoff. But with children, the extent of normal typically falls lower, so we might use a higher number as a cutoff for children than we would for adults. In addition, we'll look for associated craniospinal anomalies right at the craniovertebral junction. Cervical instability, which can be related to platybasia, which is an increased clival angle, an increased angle between the base of the skull and the spine. It can predispose to basilar invagination, which is a condition where the skull is sitting a little bit low on the spinal cord, and the spinal cord, sitting a little low on the spine, and the spine can be pressing against the spinal cord. And then it can also be associated with spinal anomalies, such as Klippel-Feil anomaly, or some other malformation of the upper spinal canal and the spinal column. It can also be associated with abnormalities of skull formation, like craniosynostosis, severe cases of craniosynostosis. Chiari ultimately is a very rare condition. It happens only in about an estimated 50 per 100,000 people, so it's not common. But it is important to note that about a third of Chiari decompression operations are performed in children. So this is very frequently seen in children. Now, what are the treatment options for Chiari malformation? So the treatment is surgical. There is no medical treatment for this condition. But there are some variations for surgery that are worth understanding when you're speaking with your surgeon about treatment options. We can offer kind of three variations of a Chiari decompression. The goal of surgery ultimately is to provide more room for those neural structures that are crowded at the bottom of the skull. One way we can do that is by removing the bone in the back. For the most part, it doesn't affect the structural integrity of the spinal column or the craniovertebral junction. We just take off the back and provide more room. Now, a lot of people will argue that the results with this, with a bone-only decompression or removal of just the bone, aren't good enough. That it requires expansion of the dura behind there, which can also constrict that space. And so, a very common approach is to take off the bone and then open up that dura and then put in a patch to provide further expansion of the space. Some also argue that this is not just a condition of crowding, but also, this is a condition of abnormal CSF flow, and that it's necessary to open up the CSF flow pathways to normalize them. And in order to do that, we'll very frequently elevate the tonsils, the part of the cerebellum that's sitting too low. We'll elevate those back to a normal position in order to create space. Finally, I spoke a little bit about the association with cervical instability. If there is demonstrated cervical instability, then surgery might also include a occipitocervical fusion, but that is a very, very rare situation where something like that is necessary. Now, this is just an image depicting what all those treatment options that I just went over are or include. So this is looking at a child from the back, and this is the bony opening here. We take off the back of the first cervical vertebra and open up a little bit of bone back at the base of the skull in order to provide more space in the back. Here you see a patch has been sewn in into the dura in order to provide more expansile capacity. And then you can also see that the tonsils, the cerebellar tonsils, have been elevated here and here to a normal position above the foramen magnum, where normal CSF flow can occur. Now here at UCLA, our strategy is typically to do the complete operation the first time and try to take care of everything all at once to minimize the risk that someone might need a second operation, that the first one might not be adequate. So I'll typically perform a suboccipital craniectomy, the C1 laminectomy, the tonsillar elevation, and the duroplasty. And one aspect of this operation that I found is very important to really maximize the benefit for children, particularly with syringomyelia, is to look at the obex right here, the outflow of the spinal canal, the central spinal canal. Very frequently, you'll find a scarred webbing overlying it, and by releasing that, we found that our results in terms of resolution of syrinx is exceptionally good. This picture has that previous picture turned on its side now. This is towards the head, and that is towards the feet. That's right side, and that's left side. And you can see again that the cerebellar tonsils have been lifted up to a normal position here and here, that the obex is nice and open, and that the CSF flow pathway is nice and open. So the reasons to do this operation. Part of it is that the natural history, that is, if this condition is left untreated, is a little uncertain. Because we've been treating this condition for pretty much as long as we've known about it, we don't know how bad it gets if we leave it untreated. But we do know that the overwhelming majority of patients get better, both radiographically and in terms of symptoms after treatment, and that this treatment is extremely durable, in that the huge majority of patients need one surgery and they're done. We know from Dr. Marasco's group, this was published by Jennifer Straley, that the resolution of syrinx with an adequate Chiari decompression in children is very good. Those rates published were around 75% that the syrinx was diminished, and this was confirmed looking at Richard Ellenbogen's enormous series from Seattle Children's, where when he explored the obex, he found that the rates of syrinx improvement was even higher by properly exploring the obex. In his group, in Dr. Ellenbogen's series, we also found that greater than 90% of patients would experience symptomatic benefit, and the complication rates were just exceedingly low with this operation. So what we do know about the pluses and minuses of treatment are that the potential risks are exceedingly low, that the potential benefits, the rate of benefits are greater than 90%. And really it's just being judicious about the cases where someone has slightly low tonsils but no other associated radiographic or clinical abnormalities. So this is kind of what the typical appearance after surgery. This is the same patient from before. You can see that the tonsils are now in a normal location, that there's plenty of space behind the brainstem here and in front of the brainstem here. I would be happy to take some time to answer some questions now. Thank you very much for your attention. So, is Chiari surgery always successful, and how do I weigh the risks and benefits? Well, that's the perfect question coming from a parent of a child with a Chiari malformation. It's not always successful. A lot of it has to do with choosing the patients who are most likely to benefit. So we talked a little bit about using cutoffs, radiographic cutoffs for a Chiari malformation. Now, what you see there is just that the tonsils are sitting at a certain level below the foramen magnum. If they have that, do they have a Chiari malformation? Do they need surgery? Well, that's when you really need to consult a neurosurgeon. That's when there's a decision to be made. In some cases, there is a syrinx associated, or a child has obvious compression symptoms, and in those cases, we essentially always recommend surgery, because we know that we can do the surgery with again, exceedingly low risks, and that the rate of success is going to be very, very high in terms of relief of symptoms and improvement of radiographic abnormalities. But then what about those cases where the tonsils are sitting a little bit low and the child doesn't have any symptoms and doesn't have an associated condition that might suggest that pathology? Well, in those cases, we want to be really careful about offering surgery. I will commonly watch with serial imaging over time and see if there are signs that Chiari malformation is slowly causing problems. One important thing to realize as a parent in this situation is that the Chiari malformation is not an emergency, and that that if it's not black and white as to whether surgery should be done, then you have time to wait. What causes the brain deformity? Are there genetic factors, and then can it be prevented? So several genetic studies, really high-quality genetic studies, have been done by a group at Duke University looking at whole genome gene expression arrays, trying to find a genetic kind of predisposition to this, and they found some candidates. A couple of chromosomal abnormalities have been found kind of repeatedly in some of these patients, but we have not found that they're inherited, that they're heritable. So what we do know about the condition is that certain genetic abnormalities that can happen spontaneously, sporadically, might predispose a patient to developing a Chiari malformation, but that it is not a strictly genetic condition. Again, thank you very much for joining me today. I'll look forward to helping you out however I can. Please feel free to contact me if I ever can.